Hello, everyone, and thank you so much for joining us today for our webinar, Understanding Blood-Based Testing in Cancer Care. I'm Shelley Fuld, Nasso, CEO of Cancer Nation, and I am excited that you've joined us today. We have a really great panel of experts to talk about blood-based testing in cancer care. I want to thank our speakers first and our great staff at Cancer Nation who helped put this together, and also Guardant Health for sponsoring this webinar. We have three experts to speak with you today. Dr. Suzanne Fuqua is the professor of medicine and molecular and cellular biology at the Baylor College of Medicine in Houston. Dr. Kelly Shanahan is the president and board of directors of the board of directors of Mediviver, and she's a retired OBGYN who has been living with metastatic breast cancer for many years. And Jennifer Leib is the founder of Innovation Policy Solutions and is going to talk to us about some of the policy implications of blood-based testing. We're going to put a link in the chat to their bios so you can learn more about them, but I wanted to leave as much time as possible for them to talk. So we know that blood-based testing is very exciting potential innovation in cancer care. One of the things that we see every year in our cancer survivorship survey is that fear of recurrence and that anxiety, the constant fear of progression or recurrence is a huge issue for people living with cancer and people who are post-treatment for cancer. So the idea that we could have blood-based testing instead of or to complement scans is an innovation that could really help cancer patients. And we're going to learn more about some of the movements in that direction, where we're going, hear a patient perspective, and then hear about some of the policy implications. So I'm going to turn it over to start with Dr. Fuqua, who's going to talk to us about the science that she has been working on in blood-based testing in breast cancer.
Thank you, Shelley. This is the first time that I have worked with Cancer Nation, and I've been very excited about giving this. Next slide, please. Although I am going to focus on breast cancer because that's my area of expertise, what I'd like to do is guide any listeners here on the webinar who are interested in other cancers to please take a look at the 2026 ASCO abstracts. Both Guardant Health and Signatera have greater than 30 abstracts of current clinical trials, and it's very exciting. I've taken a look at some of these. So I really guide you. I think I'm going to tell you the principles, but to really be guided for specific cancers, the heme, logical, the colon, please refer to ASCO. All right, so testing in cancer. So it's a simple blood test. It tests for little tiny fragments of tumor DNA called circulating tumor DNA, ctDNA in the bloodstream. There are assays that detect whole cancer cells and proteins. Those are less sensitive, so I'm going to focus on the ctDNA test today. So you can watch cancer over time with less invasiveness. So you get snapshots of whether cancer is spread, and it is less invasive than tissue biopsy, just being a blood-based draw. So it adds to, but does not replace tissue biopsy and scans. So it complements, okay? It doesn't replace, and it gives us really real-time information. Next slide, please. Okay, what can it do? First on the left, you can screen for cancer before it happens. Colorectal would be one example. Not so much in breast cancer is it used to screen beforehand. So it's used to detect abnormalities, to follow up something found on imaging. Second, it can find targets to guide therapy. So you sequence the patient's sample, or, and I'll talk about the other way to do it without sequencing, so you can detect mutations of cancer like our driver genes, PIK3CA, and that helps guide your treatment, personalized therapy. I think one of the most useful for those of us who are breast cancer survivors and advocates is that it can find evidence that cancer is coming back. So minimal residual disease, MRD, can go very deep, very low levels. Almost if you get a positive signal, it predicts with about 98% accuracy. So you can see if the cancer is gone with your treatment or come back. And of course, it can reveal resistance after targeted or hormone therapy in the case of breast cancer. We know as tumors evolve, you can uncover new mutations. An example is the mutated estrogen receptor, which I discovered in my early research a number of years ago and have worked on this area in my entire career. Next slide, please. First off, standard of care for ER-positive breast cancer. So we had tamoxifen in the early days, and then tamoxifen was replaced by an aromatase inhibitor, an AI, in both the adjuvant setting and then in the first-line metastatic setting. And then we had combinations of drugs with CDK4/6 in the metastatic setting. So what happened was we've had widespread use of AIs. So in the adjuvant setting, 5 to 10 years, and then you use it again upon first recurrence. And what we know now is that mutations can evolve on an aromatase inhibitor and emerge in and metastatic. Blood-based CT monitoring can spot these mutations months before a scan. And we can switch to a new generation of drugs called selective estrogen receptor degraders based on the ctDNA, and we can extend time before cancer starts growing again. So that's progression-free survival. And I'm going to show a few of the trials and the data to show you how it's helpful. Next slide, please. So, yeah, we can go ahead. It's fine. No, it's fine. Go ahead. So what I've just been talking about, aromatase inhibitors on the left block estrogen. Okay. SERMs called modulators or tamoxifen, the older drug. It would block the binding of estrogen. And our newer drugs, for instance, fulvestrant and elacestrant, they actually degrade the estrogen receptor. So what we've had happen is now a new generation of drugs that are even better degraders. Next slide, please. But first, let's look at the data, okay? So we started testing for mutations, okay, after the treatment. And we found, and you can see that third column from the left, is that patients undergoing these therapies were developing very high percentage of ESR1 mutations. Okay. And if you take a look on the right, the progression-free survival is short, even with these combination drugs, the best drugs we had at the time. And I have to say, in 1997, I predicted this would happen. That if they were present in a lot of metastatic tumors, it would contribute to cancer progression and hormone resistance. And that's exactly what the ESR1 mutations do. They actually are drivers of progression and resistance. Next slide. So the good news is we have these newer SERDs, next generation SERDs. I already said elacestrant's been approved for a couple of years. It's approved for ESR mutant tumors only after progression on standard of care. We now have imlunestrant that just is this year. It is also approved for ESR1 mutant tumors. It's more of a pure antagonist and degrader, and you can look at the classical trial and the improved PFS. Just happened a couple months ago was about degistrant. It is a PROTAC, even a better degrader than the SERDs. And again, it's approved for ESR1 mutant tumors after progression on standard care, along with the companion ctDNA test Garden 360. And you can see again, it was improved PSF that led to the approval. Next slide, please. Okay, so we can use on the far left neoadjuvant. So let's say you have triple negative cancer. We don't really have a target for it. We use chemotherapy. This is all what the I-SPY trials is all about, is to treat before surgery and then monitor after surgery response to the neoadjuvant therapy to help guide treatment or switching. The newest use is in the adjuvant setting, early disease, like I have, and that is where you have the potential, if your cancer is coming back early, to switch. So it detects recurrence before scans can. It also then In the metastatic setting, when you do have recurrence, it can be used for therapy guidance and the emergence of other forms of resistance. So you can see that it can really be used in the span of treatment, and the same can be said for other cancers. This is just the example with breast. Next slide, please. Uh, let's talk about the test. There's a tumor agnostic. Guardant 360 is one example where they use all known breast cancer genes that are mutated, colon cancer genes. So it is without looking at your primary cancer, that is the test. The second is tumor informed, of which Signatera is one. It's where they sequence your cancer after surgery and make a personalized test for you. And there is a trade-off for sensitivity and convenience. Next slide. Okay, so here's an example of Signatera, FDA approved to monitor the neoadjuvant setting, the minimal residual disease, monitoring response to immunotherapy, especially in triple negative, and then monitoring response to adjuvant therapy as I described for myself. Next slide. All right, so let's take a look at the test. It's custom built blood test, a sequence of your tumor. That gives it exquisite sensitivity because of that. Now, of course, tumors can evolve. It might miss something that evolves, but that is the trade-off in this test. What are the cons? Increased anxiety of positive results. I have several friends who had very low positive results and they're having to wait it out. They're doing more frequent monitoring of their cancer, getting more scans than they had planned. And I understand that. But the pro, and in my opinion, in my circumstance, I know what mutations cause my cancer. Okay. And I will know how to switch treatment if the cancer comes back. So I can have earlier treatment intervention. So for me, it gives me an assurance that I'm doing all I can do with what I have. And I know what I have because of the sequencing. So it's proactive. It's not just waiting for your cancer to come back. Next slide, please. So what shown you is that endocrine therapy is rapidly evolving. Unfortunately, the cancer is shown on the diagram on the right is also rapidly evolving. And what we've learned for the number of 20 years in preclinical translational research is the earlier you can catch it, the better. Before you have so many mutations, there aren't targeted therapies to all of them. Again, so that's a big proponent. Not only that our therapies are getting better, but we're catching it earlier before they evolve and get really bad and resistant. Next slide, please. So I might have just two updates. So now in the adjuvant setting. So part of my frustrations were using all these new drugs, but only in the metastatic setting after standard of care. But they moved earlier. And so this was a study with a drug called giredestrant, and it showed superiority, excuse me, in the adjuvant setting. And the beautiful things, it wasn't just better DFS, okay, and less likely to develop progression. But you also had wonderful quality of life. And I call this practice changing as I do the next slide, please. The most recent trial that was reported out in San Antonio here is Serena 6. So it is a switching trial. So if you look at, if you measure ctDNA, you're on standard of care. If half the study, if you developed an ESR mutation, switch to the better drug, again, a surge camizestrant, okay? Reduced progression by 56%, reduced deterioration of quality of life. It was just amazing. Again, I call this trial practice changing, okay? We're doing things earlier and not waiting till it's so late. My views as a cancer researcher, this is my views, and not everybody agrees with me, for certainly. The FDA did not agree. They voted 6-3 against the ctDNA guided switching strategy. My questions are, is the bar different when intervention is guided by a blood test and not a scan? There is an absence of crossover that's been discussed. What a crossover does is it isolates the effect of timing and contamination of the arms. And finally, is resistance being held to a different standard? And those are questions I think we need to debate as advocates and researchers. Next slide, please. So I am here being a long-term translational scientist, being now a patient advocate and breast cancer survivor myself. I certainly see things from a different perspective. And I want to thank you to patients who participate in the clinical trials, donate tissue for research that we work on, and that's how we've come through with all of our clues. And my funders are on the right, and I thank you very much.
Thank you very much, Dr. Fuqua. I really appreciate it. I think the fact that you are a breast cancer survivor yourself does give you that different perspective when you're doing your research. And you're very modest because you mentioned that you discovered this, but I think people just need to understand like how important that is that you found this mutation that is now, leading to better treatments for people. So thank you very much for that. Now,
Thank
excited to turn it over to Dr. Kelly Shanahan, who is here as a patient advocate, not a clinician, even though she is a clinician, to really talk about her perspective as a someone living with metastatic cancer and the promise of testing, blood-based testing in conjunction with or instead of, or however it's going to work in clinical practice. So Kelly, please take it
Thank
away.
you. Thank you, Shelley, for inviting me. Thank you, Suzanne, for that wonderful overview of some of the blood-based testing, especially in the breast cancer space. And I know there are a lot of people on here that don't have breast cancer, and I have stage 4 metastatic breast cancer. So I come from that perspective, but a lot of the perspective, it carries through across cancer types. Um, certainly the ability to go and get blood drawn out of your arm or saliva or urine, because these tests theoretically could be done on all sorts of bodily fluids, um, versus having a large gauge needle stuck into your body for a tissue biopsy or an open surgery to get tissue is very, very much wanted by patients. There are a lot of different types of biomarkers. There are biomarkers that can let us know how well we might do with treatment. There are biomarkers that determine what treatments we are eligible for, and that precision medicine is becoming more and more and more common across cancer types. So many of the drugs that are being approved now are being approved based on whether or not you have a particular mutation, whether you have a ROS mutation, EGFR in the lung cancer space, a RAS mutation. A drug was just approved in the pancreatic cancer space that targets RAS. PIK3CA across different cancer types, HER2 across many different cancer types. So it's becoming more and more important. And I think the benefits far, 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 far outweigh any risks of blood-based testing. Are there pitfalls? Yeah. Um, Not everything's picked up. Our cancers may shed such a small amount of circulating tumor DNA or even circulating tumor cells that they can't be picked up by currently available testing. But the testing is improving so that minuscule amounts of these things are, probably will be able to be picked up in the future. We also don't necessarily know what to do with mutations. We have drugs for certain mutations, but there are lots of things that our cancers mutate to and produce that shed in our bloodstream that we don't have any therapies for. And I think, going to a lot of the scientific meetings, I'll be heading to ASCO next week, and we'll hear about this, that biomarker testing like this is not ready for prime time. And I think we're getting closer to that prime time. And I think if we need to do this testing, we need to collect the data. We need to have large registries where this data is collected, because if we find out that mutation XYZ is present in a significant number of people, then maybe the researchers will look at mutation XYZ, and several years down the road, there will be a treatment available. People ask, what about, oh, I don't want to do this testing, especially the monitoring testing, not testing when there's progression, which is the current paradigm, especially in the metastatic and advanced space. Your disease grows, you see new tumors or increased size of tumors or increased intensity on PET scans. and you get a liquid biopsy done. But now there are people that are doing Signatera as monitoring, doing other tests as monitoring. Dr. Fuqua talked about the Serena 6 trial, which looked at switching therapies based on development of a mutation rather than waiting to see progression on imaging. And as she mentioned, the FDA was not thrilled with this. And I think there are some reasons. And one is we don't currently know whether switching early when the mutation develops, excuse me, versus switching later when there's progression does make a difference. And unfortunately, in Serena 6, they did not allow for what's called crossover, so that the people who stayed on their original therapy, when they had progression on imaging, that they switched to the camizestrant, the investigational drug. And I think it would have been a better trial if that had happened. Excuse me. Um, but I do think that, the people that say, oh, we shouldn't do this because the patients are going to worry, that is a very outdated, paternalistic attitude. I think each individual person needs to have a discussion with their doctor, and talk about the pros and the cons of the testing and let us make decisions. I know that I go into a rage if my test results are not available to me quickly because they're my test results and I know I can handle it. Um, but everybody's different, and I think it has to be individualized. But I don't think blanket prohibitions on releasing this information or not doing this should be done. It should be up to the individual patient after discussion with his or her individual doctor. I do think Dr. Fuqua also mentioned this, the difference between tumor agnostic testing, like that Guardant 360, or more some of the Foundation Medicine tests that are done on everybody. It's the same panel versus tumor informed, where you have to have a biopsy of either your original tumor or a metastatic spot. And there are pros and cons of each, but I do have concerns about the tumor informed testing if you do develop a new mutation and that's not picked up. So I think there needs to be some combination of both. I do think that this is the future. I think that our regulators, the FDA, the European medical groups, are going to have to think outside of their typical box of radiologic progression to look at molecular progression. But we still need data from trials that are ongoing to see whether the early switch makes a difference in how long we live. Um, with this disease. I also think one of the problems with the Serena 6 trial was that while they looked at quality of life and they showed that the early switch improved quality of life, that was a secondary endpoint. And I think if it had been a second primary endpoint, a co-primary endpoint, that maybe the FDA would have looked at things a little bit different, because the people that had an early switch that switched from a drug called an aromatase inhibitor, which causes a lot of joint pain, makes you feel like you're 105 years old, a lot of joint stiffness, a lot of joint pain. Then patients that switch to camizestrant, this investigational selective estrogen receptor degrader, had a much better quality of life. And I think if that had been a co-primary endpoint, that maybe the FDA would have had the panel, the ODAC panel would have had a different vote. We don't know yet. The FDA as a whole hasn't said whether they're going to approve or not approve this drug. Um, so we'll have to see. I think that's where patient involvement in the design of clinical trials is really important. I think if people living with disease had been involved in the design of any of these trials earlier, we would have had better questions to ask. We would have brought up some of the issues with what the endpoint should be, how the trial should be designed, and we might have been having a different story, especially when it comes to Serena 6. Interestingly, another drug was discussed at the same day, and they had a patient representative that spoke, and the ODAC ruling on that drug was favorable. So again, nothing about us without us. And I think that we, as experts in lived experience, need to be involved in the design of all these trials. But biomarker testing, liquid biopsies are here. I love a biomarker. I want biomarkers information on biomarkers collected in every trial, even if it's collecting blood and saving it for later to look and see if there is a biomarker, because it's the wave of the future, and I think it's going to make a difference for all of us. So thank you all very much.
Thank you, Kelly. You hit on so many important points. I love the reminder of nothing about us without us. And also, I think you and Dr. Fuqua both talk about the policy implications here. So as you said, that the Oncology Drugs Advisory Committee, or ODAC, that met a few weeks ago, they make a recommendation, but the FDA still has not made a decision on this drug. So that's one kind of policy implication here. But another one is, how do we cover the testing, especially when people might need repeat testing in order to do this kind of ongoing monitor. And that's what Jennifer Leib is going to talk to us about and explain some of the policy issues around the current coverage and what we need to change in order to, so that, as Kelly says, this is sort of coming, this is the future. So how do we make sure that patients have access in the future as we have more and more situations where this blood-based testing is an ongoing part of the clinical care.
Yeah, thanks, Shelley. And then those are the previous two presenters really summarized well the evolution of the science and how treatment has evolved over time and the options that are available to patients. And more importantly, how understanding the genetic makeup of the tumor, those precision oncology diagnostics, has really informed and improved patient care. And it's really important that insurance coverage policies align with the innovation as it's coming into the market, and more importantly into clinical practice, and so that patients don't have that as an access barrier to these really important advances in cancer care. So I'm going to focus particularly on one area of insurance, Medicare. And the reason why I'm going to focus on Medicare is it is the largest insurer in the United States. Over more than 65 million people are beneficiaries enrolled in Medicare. So if you get a good coverage policy within Medicare, you're actually benefiting a significant percentage of the population. Additionally, because of that, a lot of other payers, so even state Medicaid programs and a lot of the private and commercial payers, will follow Medicare's lead. So if Medicare sets a really robust, good coverage policy, that oftentimes will translate into coverage in other types of insurance. So next slide. There's two main ways in which Medicare sets a coverage policy, and one is the National Coverage Determination Process, or NCD. And it's important to note that word national. So this is a way for Medicare to say, we're going to establish coverage for a procedure, a diagnostic, a surgery, et cetera, any type of medical care that a beneficiary may need. We're going to set it on the national level. That means no matter where you live, no matter where you get your care, if you're enrolled in Medicare, you get coverage for this. And it's a pretty straightforward process. The schematic is super simplified, but it's really what it is. Someone requests that an NCD be initiated. And if it meets the criteria, that it includes all the necessary data, information, et cetera, in that request, then Medicare will initiate that. And once it's initiated, they usually make a decision within 6 months that's open for comment, and then finalized soon after. If they need more input or expert opinion, they might consult an external advisory committee. But essentially, it's a pretty streamlined process. About 10% of coverage policies in Medicare are set via the NCD process. So it's a small percentage of coverage is set on the national level. And that means that and part of the reason for that is because it's quite a labor-intensive process for Medicare officials. So next slide. So CMS, which is the agency that administers Medicare, keeps a dashboard on its website. And they last updated it March 2026. I checked again yesterday. So this is the most up-to-date data. They currently only have 2 of those NCDs in progress. If you look at the preceding 12 months, so March 2025 to March 2026, they only finalized 6. So that just gives you a sense as how difficult this process is and how important NCDs are, that if they're going to establish coverage for everyone enrolled in Medicare across the country, they want to really invest the resources and time to make sure they get it right. On the right, very right, you see the wait list. There's currently 11. And next slide. These are the list of 11 NCDs on the wait list. So even though today we're really focusing on precision oncology diagnostics, as you can see here, they use NCDs for every type of possible clinical scenario that a patient may need coverage for. And because it's such a difficult process, it's not uncommon for these NCDs, which have all met the criteria, so Medicare has accepted that they're going to pursue this, they sit on this wait list for sometimes 1, 2, or even more years. And so advocacy is really critical in making sure that Medicare sees this particular NCD as a priority and moves it ahead of the line. So next slide. So how is the rest of the other 90% or so of coverage set in the US? And that's set on the local level. And so Medicare is a huge program. It's one of the biggest programs in government. And a way to make it more feasible to be implemented is Medicare divides the country into regions, which are denoted by color on this map. And then they award contracts to Medicare administrative contractors, or typically insurance companies, to administer the Medicare benefit, the insurance program for those regions. So you can see here, the bubbles, the circles are the contractors who represent different regions. So your care, the coverage you get under your Medicare plan, depends where you live. So a patient living in Michigan versus a patient living in California may have different coverage policies on the local level. So that's a really important distinction. The reason, and again, pointing to why a national coverage policy is so important, because it gives coverage across the country. Next slide. The LCD, or local coverage determination process, is somewhat similar on the national level in that there's public comment engagement. They will consult outside advisory committees and even have a public meeting if need be. I think an important distinction is that while NCDs can languish on a wait list for a while, if an LCD is not finalized within a year of it being initiated, it actually expires. So next slide. I want to focus, though, on one particular national coverage determination, 90.2, which is titled Next Generation Sequencing, because this is the current federal coverage policy that applies to all of the tests that Drs. Fuqua and Shanahan just described in their remarks. This is the coverage policy that provides screening for all of those tests that are performed on the tumor, whether the tumor genetic material is isolated from a blood test or a biopsy or otherwise. This is how Medicare determines whether or not that beneficiary will have coverage for it. So the policy says that if you are a patient with late stage cancer, so stage 3 or stage 4 metastatic cancer, you previously have not had this test, you do plan to get more treatment, and the test is FDA authorized, then Medicare will cover the test. So it's pretty simple policy, straightforward. And what you heard this morning is some of those gaps, right? We heard that testing is moving more toward early stage cancer, that all patients could benefit from having an understanding of the genetic content of their tumor. We're also hearing about monitoring, so the importance of repeating testing over and over again. And so you can start to see some of the gaps that lie in the coverage policy. Very quickly, it also provides some coverage on the national level for hereditary cancer testing, or your risk of developing cancer. It's narrowed to just those with breast and ovarian cancer. And of course, also the test has to be FDA authorized. So recognizing some of these gaps in the coverage policy, Medicare did put a little wiggle room and a little discretion in the NCD as well. Next slide. And go back, perfect. And so we talked about how policy can be set on the local level. And so in the national coverage determination, 90.2, there is some discretion given to those MACs. And in particular, on the somatic or tumor side, that it's still narrowed to stage 3 and stage 4 patients. It's still narrowed to one test per lifetime, but it doesn't necessarily have to be FDA authorized. And that's important just to point out. It could be an entirely another policy topic, but the vast majority of clinical laboratory tests in the US currently are not FDA regulated. So we want to make sure patients have access to all types of testing that their providers feel are important. And in this aspect of the NCD, it gives that discretion to the MAC to say, hey, this test is still high quality, we're going to cover it. And it does the same thing on the hereditary side as well, and also expands it beyond breast and ovarian cancer. So if you have a hereditary colon cancer history in your family, then the MACs at the local level could provide coverage. But again, because this is discretion, it's left to the MACs, it's on the local level, that depending where a beneficiary lives or where the test what state the test is performed in, there might be discrepancies or disparities in access and coverage. So having a good and robust national coverage policy is really important. And next slide. And the study's already been discussed, so I won't go into it too much, but this is an example of innovation coming to market where we think there is going to be a need to do monitoring testing with a companion diagnostic that's looking at tumor circulating in the blood, and that will then determine whether you switch treatment for between different medications for breast cancer. And unfortunately, the current NCD would not cover this. So we don't know what FDA is going to ultimately decide if they're going to authorize this new product or not. But if they do, we want to make sure that the Medicare coverage policy covers it, that policy is in place, ready to go when this new product is available to clinicians and patients. And so what we need to do is update the NCD to make sure, one, it can be used at any stage of cancer, so stage 1, 2, 3, or 4, early, late stage, et cetera. And two, that it can be that the NCD covers repeat testing so that you can have testing for monitoring for minimal residual disease and so on. So next slide. So in order to advocate for that change in the NCD, we formed the CancerDx Access Alliance. And this really is an informal alliance of stakeholders to advocate for what's called a reconsideration request, which is encouraging CMS to reopen that policy and CD 90.2 and go through the process to update it so that it reflects where innovation is today. The alliance includes members from patient advocacy, provider space, industry, everyone who doesn't have like a clear home to advocate for this. Either there are some industry coalitions already prioritizing this issue, but there's lots of other stakeholders who don't fit in those memberships. And we wanted to create a forum for them to be able to engage in this discussion and have a literal seat at the table, especially on areas of the reconsideration, such as when there's a public comment process, and when we need to advocate to make sure it doesn't languish on that wait list for 1 or 2 years. So next slide. So these are our current members of the Alliance. Would welcome anyone tuning in who is interested in joining. Feel free to reach out to me. We'd love to have more people participate because the strength of any alliance is made up of the diversity of its membership. And next slide. And this is what our initial scope of work is and what we're trying to do. I'll say that the Alliance was created really in February, so it's very new. And right now we're still in those initial stages of building consensus among all the different participants in the Alliance so that we can have a clear, unified message to advocate both directly with Medicare and with other policymakers and stakeholders. And again, the ultimate goal is to support the reconsideration request to encourage the updating of this Medicare policy. So with all this new innovation in cancer genetic testing and precision diagnostics comes to market, patients have insurance coverage for it. So with that, happy to pass it back to you, Shelley.
Great. Thank you so much, Jennifer. We have a bunch of questions, so I think we're going to bring everyone back so we can go through the questions. There's some that are more clinical and some that are about the policy side. So first question I have is, we've been hearing a lot about the use of AI and pathology. And you all, I don't know if you all know this, but do you know the degree to which AI is used in the analysis of these tests? Or does that complement the use of AI in pathology?
I don't know whether
Yeah.
AI is used. I'm sure it's been used somewhere in developing some of these things. And AI in pathology is an emerging technology that I think is going to help. And we have like huge waits for mammography right now, diagnostic mammograms, especially because of the lack of radiologists to read it. But I'm not aware, so I don't know whether, Jennifer or Suzanne, you guys are.
Yeah, so I went to a meeting in January where several of these companies were there, and some that are, huge companies. And AI is everywhere. AI is there for pathology. AI is there for all the next gen sequencing. And goodness gracious, now we're looking at epigenetics, which is beautiful. In my talk, I talked about how a tumor evolves. A lot of that is at the epigenetic not mutation level. And so all this is being incorporated together into one test. So stay tuned. I think it's evolving rapidly, incorporating multiple things, not just pathology, into the test.
Yeah, no, the FDA is asking for comments or requests for information on the use of AI in clinical trials, which I know Mediviver just, crafted something commenting on that. AI is here to stay, living where I live. There are environmental concerns about the use of AI, but it's here to stay, and we need to learn how to use it effectively, and have patients involved in everything having to do with AI in oncology.
Great, thank you. So from a clinical perspective, I know we talked a little bit about this, but I just thought if we could reiterate sort of what are the biggest benefits of these tests, and then also how important is the turnaround time and ease of testing?
You want me to handle some of that?
Yeah, you can start and then
Yeah, then everybody can jump in.
yes.
I think the biggest thing is sensitivity. Okay. Sensitivity and then having a tumor-informed test. Again, being a scientist, but also as a survivor now, I want to know what's going on, what's changing, right? And I may then be pushing certain new therapeutics, targeted therapeutics because of it. So I think sensitivity be my number one, and ease. It's easy, right? You get a result in about a week from a blood test. So yeah.
Yeah, and it usually, as a patient who's had multiple liquid biopsies, who has been on treatment that has been determined by mutations that I have, who is currently on a phase 1 clinical trial that, while for my particular cancer type is not requiring a mutation, this trial that I'm on is also open in colorectal and non-small cell lung cancer, where certain mutations are required. It does usually take as Suzanne just said, about a week for the results to come back in, and that's a business week. So I think we need to be clear on that. It's usually about 7 business days. So if you have a test done on a Thursday, you may not have it back by the next Thursday. It might be Friday, it might be the following Monday. But I think that's a reasonable amount of time, because sometimes it takes that long for us to get imaging reports put on our patient portals. Sometimes it's a lot faster, but some people are waiting, and um, so I think that's a reasonable amount of time to wait for this type of testing. Um, can there be anxiety while you wait for the test result? Yes. Just like waiting for all of our other test results. And I know that for me personally, I had a lot of that anxiety waiting on scans when I was first diagnosed with metastatic disease. But then someone, and I don't remember who it was, but someone said something really brilliant that resonated with me. It already is. So
Mhm.
whatever the results are, they already are. They are that when you had the scan done, when you had the blood test done. And for me, that's really helped me tamp down that anxiety. I've also been doing this for over a decade, which I think helps as well.
I guess the last thing I'm going to add, totally agree with you, is the possibility of catching it early before it has evolved. I cannot stress that. Cancer changes quickly and goes to different sites and has different cancers at different sites. So to be able to switch therapy before it's gone through that evolutionary process, I think is essential if we want a curative outcome someday, right? So just want to stress that.
And we're still waiting on overall survival data on all of these trials that are currently going on, looking at things like early switch. In the Serena 6 trial of camizestrant, there's a tendency towards, but it's so early. There's less than 30% of people that have achieved this milestone of overall survival. So unfortunately, we're gonna have to wait a little bit longer for data on that. Um, but I agree. Biomarker testing is here to stay. It's going to expand, and we need to learn how to use it and use it wisely and develop more treatments, because if we don't have treatments for mutations, then it doesn't matter.
Can I add one thing, a
Yes.
little off topic, and that's what's happening to research right now. NCI is not funding research. Myself included may be gone in a year because of the funding crisis. So we won't have new treatments if we can't get our funding back up to what it.
And we've noticed that at Mediviver, we fund metastatic breast cancer focused research. And historically, we've gotten about 100 letters of intent, a one pager. Here's what I want to do. And then we invite a certain number to submit full applications, and then we fund whatever we can, depending on how much money we raise. For the past 2 years, we've gotten over 200 letters of intent.
I mean, that's,
Double the amount because of the issues with federal funding. And I would not be here. Not you, Suzanne, any of us diagnosed with cancer would not be here if it weren't for research.
Wow.
And so we need that funding. We need to fund basic science. We need to fund translational. We need to fund clinical trials. And we need the federal government to do it because little organizations like the one I lead, and other private foundations, we're a drop in the bucket compared to federal funding. So,
My fear
all
is,
your elected representatives, people.
well, my fear is that this hasn't trickled down to the advocate community sufficiently to march on Washington because, it's been a year and a half and another year, and I would say half of the breast cancer researchers will be gone. Okay. And it's that critical. And I keep on saying to other scientists, why aren't we doing something? Right? So if anyone's got ideas, I think we really do have to take this by the tail and shake it.
As a lobbyist here in Washington, D.C., I'll add that I think that message is getting shared on the Hill. It may not be feeling
Right.
that way back where you are, but whether the American Association for Cancer Research has its rally for medical research. There's all the different patient advocacy groups and other groups like ACT for NIH who have been advocating really strongly for research funding. And I feel confident that, despite requests from the administration to cut funding, that chairwoman of the Appropriations Committee, at least in the Senate, has been very clear of her intent to increase NIH funding. So I'm hopeful as the Congress continues to do its appropriations process this year. We haven't seen the language, the funding levels yet, but I am.
NCI is not sending out the money. People
Yeah,
on
I think that so actually Cancer Nation's on the Hill today with United for Cures, talking to members of Congress about this. I think, what the message is that the money has all been allocated, but it's not getting out to people. And I think understanding, and also the way that some of the funding that was done at the end of last fiscal year with the forward funding, I don't think that the true impact is getting across to them about when they're hearing from the administration that the money has been approved or but it's not getting out the door. So I think that's really important. I know that some of the cancer centers were on the Hill last week. So I just think we have to keep getting that message to members of Congress.
Thank you.
So matters.
Yes, it does. It does. And so actually that leads me to a question I have for you, Jennifer, about this coverage process. So I know that, that the Alliance has advocacy organizations like us and others in it. But how can individual advocates who aren't necessarily going to join that alliance, but want to try to advocate for making sure that testing is covered for them? And how do they even know if they could get coverage for these tests? Like I think, what you explained it well, kind of the national versus the local, but it seems very complicated. So how does somebody know whether they have access, and what can they do to advocate?
Yeah, I'll answer your second question first about what coverage policies do you have? And that is, we all have our explanation of benefits when you go to see a physician or get a service, like your insurance company sends it to you. The MACs will have coverage policies. CMS actually maintains a searchable database on its website where you can look at all of the national and local coverage policies. So you can look them up there to see what they are. And then a lot of the MACs have their own searchable databases. And then it gets very complicated because a lot of the molecular genetic tests are in its own database that's managed by one MAC in particular, Palmetto, called the MolDX program. And so within that, there's other policies and then beyond the LCDs and NCDs, there's billing articles that further explain it. It gets very complicated fast, but definitely contacting your insurance provider is a great way to find out what your benefits are. In terms of how to get involved in advocacy around NCD 90.2, the Alliance is meant for organizational membership. So I think one way as advocates, if this sounds like something that's important to you, is reaching out to different patient or provider advocacy organizations that you're a member of and asking them to join the Alliance, asking them to get more involved. I think that would be a really important first step. As an individual, when the NCD, if and when CMS decides to do the reconsideration, there will be a public comment period, and that is open to anyone. You do not have to be a company or an organization, or you can just be any citizen, any person who cares can comment on those policies. So that would be another opportunity to weigh in. But right now, it's more about collecting the data and evidence to convince Medicare to do this. And I think that that's something that the Alliance is really focusing on. But the more organizations who participate in it, then the better access we have to that data and information to support a request.
And we will, if there is an opportunity for comment, we will absolutely be sharing that with people and asking them to comment and giving some, some advice on how to make the comments effective. And if you have personal stories about it that you want to share, of course, they're more interested in the data, but the personal stories complement that data. So that's very helpful as well. Kelly, were you going to say something?
No, not about the policy. I was just looking at one of the questions in the Q&A, and it was someone was asking about whether we as patients get a copy of the results, and the answer is yes. If you have a liquid biopsy done, you can get a copy of the results. I have had my testing done through Guardant, and there's a portal you can sign into. Yet another portal. Um, and and they do also provide, if you have a mutation for which there's an FDA approved drug, it will say you have a PIK3CA mutation, and here's the 3 FDA approved drugs, and here are some clinical trials. So, um, sometimes the information can be a little bit dense, but that is another use of AI where people have put the results in and asked ChatGPT or some other LLM to interpret it for them. So that just to answer that question there, that yes, these results are returned to patients.
And that's helpful that they can direct you to a clinical trial, so you don't
yeah,
have to
and the thing,
do
a
that on
lot of
your
us,
own.
as we know in the cancer space, 80% of us are treated in the community. Um, and so, if you have an advanced or a metastatic or a rare cancer and you're seeing a general oncologist who treats everything, that person may not be up to date on the latest and the greatest. But again, these reports, at least I can speak to Guardant from my personal experience. It does give this information, and you can go in and you can say, hey, I saw these results and I see that there's a clinical trial. Can you let me know more about the clinical trial? And depending on your cancer type, a lot of these cancer advocacy organizations have navigators, and you can contact someone and say, I have this mutation. Are there trials? Can you help me find a trial? So I know in the colorectal cancer space, in the lung cancer space, some of the breast cancer organizations have these things to help you with it. And actually all of these testing companies also have a customer support line where you can call and they'll help direct you, give you more information.
After you've gotten the results, like you've read the results
After
in
you've
the
gotten the
portal.
results, yeah.
That's great.
And one thing, talking about coverage, 100% we need coverage for these monitoring tests. Currently, the tests, as Jennifer mentioned, are usually covered if you have progression of disease to diagnose, but not necessarily to monitor whether your treatment's effective. And again, we can all join these coalitions and talk to our elected representatives because they listen to us. Whether they do anything right now is another story, but we've got to keep pushing. And the more people they hear from, the more likely it is that something is going to happen. Because if you've got a lot of constituents bugging you about one particular thing, and these people, you have an election coming up, and these people may or may not vote for you, depending on whether you do something about it. The more people that talk about it, the more that something actually might get done.
I have a question for Jen. I know that you're talking about Medicare because we know that Medicare sets policies that then influences how private payers pay. Also, we know that roughly half of people diagnosed with cancer are Medicare age and above, or have access to Medicare because through disability, if they have stage 4 cancer or are not able to work. But I'm wondering if you've heard, Jennifer, about coverage issues with private payers. Are they kind of how are they approaching this right now? Are they deferring to Medicare or are they looking at things differently?
Yeah, unfortunately, I only focus on federal payers, so I don't know how well or robust the coverage is on the private side, other than they typically follow Medicare. But I will say that on the state level, there are a really active campaign spearheaded by the American Cancer Society to get state biomarker laws passed, which would require so some insurance plans are regulated on the state level, and I mean they've already passed them in quite a few high number of states, but it would mandate payers to cover biomarker tests, which is very much the test that we were talking about today. So I think even though I focus on the federal level, there actually is a lot of activity for those private commercial plans regulated on the state level to also cover these tests.
Great, thank you. And how can patients advocate for their own ability to get this test? I know we talked a little bit about how you can look up and see if it's covered. I have mixed feelings about this. I know a lot of the work on biomarkers is trying to educate patients on what tests they should be asking for. I don't think patients should have to ask for it. I mean, but they're not getting offered the test all the time. So that's why, to me, that's a gap in the system. And ideally, Kelly, you're the kind of patient who knows everything. You're a clinician, you know this stuff, but not everybody does and shouldn't have to figure all that out in order to get the right care. But we don't have that system right now
We
where
don't.
everybody
We
gets
don't.
the
We have,
testing.
we have to be our own best advocates. So there's tremendous inequity in the use of these tests. Um, again, I'm in the metastatic breast cancer space. Every single solitary person diagnosed with metastatic breast cancer should have genetic testing done to see if they have an inherited mutation. Every single person of metastatic breast cancer, and for frankly, most other metastatic and advanced cancers, should have a liquid biopsy done upon progression. The cancer societies recommend that. If your doctor doesn't do it, you don't need to know what specific tests to ask for. But I think as patients, we need to be empowered to say, my cancer is growing. I want a liquid biopsy. And there are many, many companies that do liquid biopsies. There's differences between them. A lot of it is preference on the institution you go to, preference from the doctor you go to. But I think all of us need to learn and to be empowered to know what biomarker testing is, what a liquid biopsy is, and if our doctors don't offer it to us, we need to ask. We have developed, or actually are developing, a biomarker education piece at Medivivor that will live on our website, and we'll blast it out on our socials, and we'll do webinars about it because this is the future. We need to know about it. Should our doctors offer it to us? 100%. But they all don't, so we need to advocate for ourselves.
Thank you. That was a beautiful way to end, I think, because we are at time. I hope that when you have those developed, that we can link to it and direct people to it, because it sounds like it'll be very helpful information for people to have. Thank you all so much for sharing your time and expertise, and for all of you who joined us today and asked very good questions. We really appreciate it, and we will keep sharing this information as our efforts on the coverage determination continue so that we can show people how they can share their experience and comments to help make this coverage available to people. Thank you so much. Have a wonderful day.